This video is on myocardial infarction. Myocardial infarction occurs when the myocardium becomes infarcted. That is the end of this video. Okay, so this occurs when the muscle of the heart does not receive adequate blood supply, and this is due to atherosclerosis. So let's do an overview on how this process occurs. So over time, lipid plaques can build up on the walls of the artery, impeding oxygen supply and leading to ischemia. The deposition of plaques can be accelerated due to risk factors such as age, obesity, smoking, high LDLs, hypertension, and type 2 diabetes. If this plaque ruptures, it can be dangerous because this can trigger the coagulation cascade. A plaque with a weak fibrous cap or large necrotic core are more likely to rupture. If a thrombus forms, it can cause complete occlusion, leading to myocardial infarction or acute coronary syndrome. There are three main conditions under acute coronary syndrome. If this blockage is reversed, it causes unstable angina. If it is only a partial blockage, it causes a non-ST elevated myocardial infarction. If there is a complete blockage, it causes a ST elevated myocardial infarction. These last two are clinically differentiated on an ECG. So due to infarction, the myocardium undergoes necrosis, releasing troponins and CKMB, as well as lactic acid. The lactic acid causes chest pain that radiates down the arm and to the jaw. As the heart is not receiving adequate oxygen supply, there is sympathetic overload leading to nausea, vomiting, fatigue, and hyperhidrosis. The heart is supplied by lower cervical and apothoracic nerves from the sympathetic chain. This explains the radiation down the arm and to the jaw. As the heart muscle is not receiving adequate oxygen, there is reduced left ventricle contractility. This leads to blood congestion in the pulmonary vasculature, leading to pulmonary edema and ultimately dyspnea, or PND. Investigations will look for evidence of an MI. So in FBCs, we would look for troponins and CKMB released from myocardial necrosis into the blood, and this requires serial testing. Troponin, unlike CKMB, is specific to myocardial necrosis. However, elevated CKMB is useful to detect reinfarction due to its relatively early clearance. Lipid profile, glucose for type 2 diabetes, and coagulation studies will also give an indication of the risk factors and the development of a thrombus in the heart blood supply. An ECG will differentiate a STEMI and a non-STEMI, so partial or complete blockage as discussed before. Imaging may include an angiogram to visualize the occluded vessel, an echocardiogram to view impaired left ventricle contractility, and a chest X-ray to exclude differentials and assess cardiomegaly. So the first step of treatment is to ensure hemodynamic stability, so providing oxygen if saturation is below 94% in a patient without severe lung disease. The patient can be given morphine to mediate pain, and with an MI, the issue, broadly speaking, is that the artery is narrowed. So we can surgically widen the artery through angioplasty or stent called primary percutaneous coronary intervention. We also want to address the cause of the narrowing, so the thrombus, with thrombolysis. If it's less than 2 or 3 hours, TPA can be given or streptokinase. Platelets are integral to the coagulation cascade, so dual antiplatelet therapy can be given in the form of aspirin and clopidogrel. In the long term, lifestyle modifications such as exercise and diet should be implemented. In terms of medications, beta blockers and ACE inhibitors can also control blood pressure. In terms of surgery, stents, angioplasty, and coronary bypass may be considered. It is also important to consider the complications that can arise following an MI. We will break this down into immediate, medium-term, and long-term complications. Immediate complications include arrhythmias, most concerningly ventricular fibrillation, because this can lead to death. Cardiogenic shock, so where the heart cannot pump enough blood to perfuse oxygen, essentially because the heart muscle isn't getting enough oxygen, as well as DVTs and PEs. In the medium term, so days to weeks following an MI, complications to be aware of include pericarditis, and if this occurs, it is known as restless syndrome. There can be external rupture resulting in cardiac tamponade, or internal rupture causing a ventricular septal defect or papillary muscle tears, causing mitral regurgitation or valvular disease. In the long term, MI can result in cardiac failure. So thank you for watching. If you learned something or found it useful, or just want to make my mom happy, please like and subscribe and drop a comment with any questions or any topic you want to see in the future.